Who defined blindness as visual acuity of less than 3/60 Snellen's chart or its equivalent? The International Classification of Disease 11 classifies vision impairment into two groups: distant and near-presenting vision impairment. Distant vision impairment, mild, presenting visual acuity worse than 6/12, moderate, presenting visual acuity worse than 6/18, severe, presenting visual acuity worse than 6/60. Blindness, presenting visual acuity worse than 3/60. Near vision impairment, presenting near vision acuity worse than N6 or N8 at 40 cm with existing correction. The major causes of moderate to severe vision impairment are as follows. First, uncorrected refractive errors, 53%. Second, unoperated cataract, 25%. Third, age-related macular degeneration, 4%. Fourth, glaucoma, 2%. And fifth, diabetic retinopathy, 1%. The major causes of blindness are: first, unoperated cataract, 35%. Second, uncorrected refractive error, 21%. And third, glaucoma, 8%. Coming to epidemiological determinants. Age. About 30% of the blind in India are said to lose their eyesight before they reach the age of 20 years, and many under the age of 5 years. Sex. A higher prevalence of blindness is reported in females than in males in India. This has been attributed to a high prevalence of glaucoma, conjunctivitis, and cataract among females than in males. Malnutrition. Malnutrition as a cause of blindness was hardly recognized a few years ago. In many cases, protein and energy malnutrition is also associated with blindness. Severe blinding corneal destruction due to vitamin A deficiency is largely limited to the first 4 to 6 years of life and especially frequent among those 6 months to 3 years of life. Occupation. It has long been recognized people working in factories, workshops, and cottage industries are prone to eye injuries because of exposure to dust, airborne particles, flying objects, gases, fumes, radiation, electrical flash, etc. Many workers, including doctors, are known to have developed premature cataracts while exposed to X-rays, ultraviolet rays, or heat waves. Social class. There is a close relationship between the incidence of blindness and socioeconomic status. Surveys indicate that blindness is twice more prevalent in the poorer classes than in the well-to-do. Social factors. Many people lose their eyesight because of the meddlesome ophthalmology by quacks. The basic social factors are ignorance, poverty, low standard of personal and community hygiene, and inadequate healthcare services.
To the changing concepts in eye health care. Primary eye care is one of the most significant developments in the field of eye health care over the last few years. The idea of primary health care has been recognized rapidly and is today recognized as the model for eye care at the community level. The final objective of primary eye care is to increase the coverage and quality of eye health care through primary health care approach and thereby improve the utilization of existing resources. Secondly, the epidemiological approach. It involves studies at the population level. And thirdly, team concept. In many developing countries, there is only one eye specialist for more than 1 million people. Increasingly, therefore, healthcare leans on use of auxiliary health personnel to fill many gaps. In India, this gap is filled by village health workers, ophthalmic assistants, multipurpose workers, and voluntary agencies. And fourth, it is the establishment of national programs. The components for action in national programs for the prevention of blindness comprises the following. Initial assessment. The first step is to assess the magnitude, geographic distribution, and causes of blindness within the country or region through surveys. Coming to methods of intervention. Primary eye care. A wide range of eye conditions such as acute conjunctivitis, glaucoma, etc. can be treated or prevented at the grassroots level by locally trained primary health workers such as the village health guides, multipurpose workers who are the first to make contact with the community. For this purpose, they are provided with essential drugs such as topical tetracycline, vitamin A capsules, eye bandages, etc. The secondary care involves definitive management of common blinding conditions such as cataract, dry cases, ocular trauma, glaucoma, etc. This care is provided in the PHCs and district hospitals where eye departments or eye clinics are established. It may involve the use of mobile eye clinics. Tertiary care is established in the national or regional capitals and are often associated with medical colleges and institutes of medicine. They provide sophisticated eye care such as retinal detachment surgery, cornea grafting, and other complex forms of management not available in secondary centers. Specific programs which includes Trachoma Control Program. The Trachoma Control Program launched in India in 1963 was merged with the National Program for the Control of Blindness in 1976. School Eye Health Services. Health education is an important component of school health service. Vitamin A prophylaxis. Under the Vitamin A distribution scheme in India, 2 lakh IU of vitamin A are given orally at 6 months intervals between the age of 1 to 6 years. Occupational eye health services. This is to prevent or treat eye hazards in industries. Long-term measures. Health education is the most important long-term measure in order to create community awareness of the problem, to motivate the community to accept total eye healthcare programs, and to secure community participation. Evaluation should be an integral part of intervention programs to measure the extent of which ocular disease and blindness have been alleviated and determine the nature of other changes that may have been produced.
Main objectives of the program in the 12th five-year plan period are: first, to continue 3 ongoing signature activities, that is, performance of 66 lakhs cataract operations per year, school eye screening and distribution of 9 lakhs free spectacles per year to school children suffering from refractive errors, and collection of 50,000 donated eyes per year for keratoplasty. Second, to reduce the backlog of avoidable blindness through identification and treatment of curable blind at primary, secondary, and tertiary levels, based on assessment of the overall burden of visual impairment in the country. Third, develop and strengthen the strategy of NPCB for eye health for all and prevention of vision impairment through provision and comprehensive universal eye care services and quality service delivery. Fourth, strengthening and upgradation of regional institutes of ophthalmology to become center of excellence in various subspecialties of ophthalmology and also other partners like medical colleges, district hospitals, sub-district hospitals, vision centers, NGO eye hospitals. Fifth, strengthening the existing infrastructure facilities and developing additional human resources for providing high-quality comprehensive eye care in all districts of the country. Sixth, to enhance community awareness on eye care and lay stress on preventive measures. 7. Increase and expand research for prevention of blindness and visual impairment. 8. To secure participation of voluntary organizations, private practitioners in delivering eye care.
In 2020, the Right to Sight is a global initiative to reduce avoidable blindness by the year 2020. India is also committed to this initiative. The plan of action for the country has been developed with following main features. Number 1. Target disease are cataract, refractive errors, childhood blindness, corneal blindness, glaucoma, diabetic retinopathy. Secondly, human resource development as well as infrastructure and technology development at various levels of health system. The proposed four-tier structure includes centers of excellence, training centers, service centers, and vision centers.